So good afternoon, everyone, and thank you for joining our webinar. We are looking forward to talking with you today, providing an overview of the MIPS value pathways and the new Urology MVP. My name is Karen Johnson. I am the Director of Quality and Measurement here at the AUA, and my role is to oversee measurement and quality improvement activities at the AUA. And this includes directing the development and maintenance of urology-specific performance measures and implementing them in AUA's Aqua Registry. Keonna, would you like to introduce yourself?
Hello, my name is Keonna Confesor. I am the project coordinator within the Quality and Measurement Department at the AUA. My role is to support processes and assist with the development of resources related to measurement and quality improvement.
Thanks, Keonna. So we're really pleased that so many have joined us, and we hope even more will be able to join a little bit later on. We know several of you, and looking forward to getting to know even more. So we're going to begin today by providing just a bit of background on Aqua, our quality register here at the AUA, and on two categories of quality measures that are available for use in MIPS, because these concepts are going to crop up throughout the remaining portions of the webinar. Then we're going to move to providing just a brief overview of the MIPS program itself, and then of MIPS value pathways, or MVPs. And then we're going to move on to introducing the new Urology MVP. So after that, we're going to move to a Q&A portion of the webinar. And you may recall when you registered that we asked for questions that you would like us to address in this presentation. And we're going to do our best to address as many of those questions as we can. And there may be time toward the end of the presentation to answer some additional questions. Before we delve into the meat of today's presentation, I want to note just a couple things. First of all, the MIPS program itself, as I'm sure you all know, is very complex. And as such, there's no way that we're going to be able to dig into the nuances of the program itself. But we hope that the things that we are going to point out today will be helpful and informative for you. Relatedly, several of the questions that you asked during the registration process were very specific, either to operations of the MIPS program or maybe to our Aqua registry. So those we're not going to be able to answer on today's webinar, but what we'd like you to do is reach out to either our Aqua registry ops team afterwards, or contact us, and we will try to answer those questions as we can. Again, if you have questions as we go through the presentation, put them in the chat function, and if we get to them, that will be great. We will try our best to. If we don't get to those questions today, or if we can't answer them, we will follow up with you afterwards. So with that, I'm going to hand things over to Keonna to get us started. Keonna?
Thank you, Karen. Move to the next slide. Let's see. Before we dive into MIPS and MVPs, like Karen mentioned, we will share some information about the Aqua registry and quality measures. Thank you again for sharing your questions in advance of this webinar. We realized that of those who registered, nearly 1/3 of you are already participants in the Aqua registry. In background information, the Aqua registry is also known as the AUA Quality Registry, which was launched in 2014 as a way to help providers track performance at both practice and provider levels. Currently, there are around 200 active practices and nearly 2,400 active providers currently participating in the Aqua registry. And within the Aqua registry, there's information about 13 million unique patients and 106 million unique patient encounters. Aqua is also approved by CMS as a qualified clinical data registry, or a QCDR. And a QCDR is an entity that demonstrates clinical expertise in medicine and quality measurement development that collects medical or clinical data on behalf of CMS MIPS eligible clinicians for patient and disease tracking to foster improvement in the quality of care provided to patients. Being a QCDR allows the AQUA registry to develop and support additional measures for MIPS reporting. For the 2025 performance year, 54 measures are currently supported by the AQUA registry, and AQUA annually has to go through a approval process to maintain its QCDR status. If you're interested in joining AQUA or have questions about your current participation in AQUA, please send an email to aqua@auanet.org or give them a call at the telephone number on your screen. As Karen mentioned before, there are some questions that were specific to the AQUA operations team that we will not be able to answer. However, we encourage you to reach out to AQUA directly for more information. Quality measures in MIPS. There are two categories of quality measures used in MIPS reporting: QPP measures and QCDR measures. QPP stands for the Quality Payment Program, which is an initiative sponsored by CMS or the Centers for Medicare and Medicaid Services. We'll talk a little bit more about QPP later in this presentation. QPP measures are also known as MIPS measures, and they can be used by anyone. They require a one-time approval through the CMS rulemaking process, and any modifications or removals for those measures must still go through the rulemaking process. For the 2025 performance year, there are 195 QPP measures available. The other type of measures are QCDR measures. Again, QCDR stands for Quality Clinical Data Registry, which is a reporting mechanism available for MIPS like the AQUA registry. These measures are not considered QPPs, and they are only available for people and groups participating within the QCDRs. These measures, unlike the QPP measures, have to go through an annual approval process by CMS. Currently, the AQUA registry is supporting a combination of 54 QPP and QCDR measures, 46 QPP measures, and 8 QCDR measures specifically. Now let's spend a few minutes talking about the MIPS reporting process. MIPS stands for Merit-Based Incentive Payment System. MIPS reporting includes the submission of data for a combination of both QPP and QCDR measures, along with other requirements. We will go into a little bit more details about the submission process later in this presentation. MIPS is a track that can be used for participation in the CMS Quality Payment Program, otherwise known as QPP. This program is a value-based payment program by which the Medicare program rewards clinicians who provide high-value, high-quality care to their patients in a cost-efficient manner. The QPP program was established via the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA legislation. This legislation changed the way clinicians are paid for providing services under Medicare. It continued the move away from fee-for-service payment toward value-based payment approaches that endeavor to pay clinicians based on the quality, value, and outcomes of the care they provide. Clinicians can participate in the QPP program via two separate tracks: the Merit-Based Incentive Program Payment System, aka MIPS, or Advanced Alternative Payment Models, APMs. In MIPS, you may earn performance-based payment adjustments for the services you provide to Medicare patients. An APM is a customized payment approach developed by CMS, often designed to provide incentives to clinicians who are providing high-quality, high-value care. APMs can focus on specific clinical conditions, care episodes, or populations. For this webinar, we will not focus on APMs today. MIPS eligible clinicians earn payment adjustments again, either through bonuses or penalties for Medicare Part B covered professional services based on 4 performance categories. The first category, promoting interoperability, or PI, assesses your promotion of patient engagement and electronic exchange or health information using certified electronic health record technology. The improvement activities category, or IA, assesses your participation in activities that improve clinical practice and support patient engagement. For the quality category, this assesses the quality of care you deliver by measuring healthcare processes, outcomes, and patient experiences of care. The last category, costs, assesses the cost of the care you provide based on your Medicare Part B claims. MIPS participants report measures and attest for the quality, AI, and PI category. CMS actually calculates the cost measures for claims data. At the end of this presentation, we will share links for you to use to learn more about each of the performance categories and other issues related to MIPS and the MVP reporting processes. For MIPS, there are 3 reporting options for MIPS. That includes traditional MIPS, MVPs, and the APM performance pathway. Later in this presentation, we will spend some time talking about MVPs, or as they're better known as MIPS value pathways. We will not cover additional information about the APM performance pathway option beyond the fact that it is a streamlined reporting framework with specific quality measures available to clinicians who participate in a MIPS APM. There are also 5 MIPS participation options: individual, group, virtual group, subgroup, or APM entity. The virtual group option is only available for traditional MIPS reporting. The subgroup option is only available through the MVP reporting options. And additional information about all of these options that are mentioned today can be found on the CMS QPP website, which we will share with you during this presentation. Clinicians also have the option to verify their eligibility for participation in reporting MIPS by entering their individual National Provider Identifier, or NPI, into the QPP participation status tool that you see on the screen. The type of provider you are and your service volume affects whether your MIPS participation status is required or voluntary. As we mentioned, there are 4 performance categories for the MIPS reporting option: quality, cost, improvement activities, and promoting interoperability. Each performance category is scored separately, and the results are then summed to get a final score. Each category may be reweighted in certain circumstances, such as if a group or individual was approved for an approved extreme and uncontrollable circumstances exception. The graphic you see on the screen represents the assigned weights for individual groups, subgroups, and virtual group participation in MIPS and MVPs. Quality, the weight for quality score is 30%. Cost has a weight of 30%. Improvement activities is 15%. And the PI category, the weight is 35% of your final score. Please note, this diagram or this visual on the screen does not reflect the weighting that is done for small practices. And again, there are resources at the end of this presentation so you can look into the small group practices and their weighting expectations. It is also important to note that MIPS is a budget neutral program, meaning that the penalties pay for the bonuses. The sum score from all 4 categories will determine whether a practice or individual or group will receive a bonus, penalty, or neutral payment adjustment. The amount available for bonus payments will be determined once CMS determines the penalty amounts. A score of 0 to 74.99 will lead to a penalty. If someone has a score of 0 to 18.75, the penalty will be a negative 9% adjustment. For scores of 18.76 to 74.99, the negative payment adjustment will be greater than negative 9% and less than 0%. A score of 75 will result in a neutral payment adjustment of 0%, and a score above 75 will result in a bonus. Additionally, CMS no longer offers an exceptional performance bonus. As we mentioned at the beginning of the session, there are 3 reporting options for the MIPS program. We just briefly discussed MIPS. We're not going to take a deep dive into the APM entity option. However, we will spend a few minutes talking about the MVPs, or again, the MIPS value pathways. MVPs are the newest reporting option. The 2023 performance year was the first time MVPs could be submitted during the MIPS reporting process. The goal of MVPs is to promote use and reporting of measures relevant to clinicians' actual experience, align measures and improvement activities, and reduce the burden of reporting. MVPs include a subset of measures and activities related to a specific specialty or medical condition. So, for example, rather than having 200 quality measures to select from if you're reporting via traditional MIPS, a clinician or practice may have only 15 measures to choose from. Those 15 measures or so will be relevant to their specialty or the medical condition of that MVP. The same stands true for IAs and cost measures. MVPs also include a foundational layer that includes the same measures that are included in the PI performance category for traditional MIPS, along with 2 population health measures. Beginning in 2025, CMS will calculate both population health measures and use the one with the highest score. In summary, MVPs in comparison to traditional MIPS have a lower reporting burden because there are fewer measure choices and the available options are more related to a specific specialty or medical condition. The graphic you see on the screen shows a few of the differences that we will explore further in the next slide. This table provides a little more information about the differences between traditional MIPS and MVPs. As previously mentioned, MIPS reporting includes a large number of quality measures and improvement activities and cost measure options. For example, for quality performance category, there are 195 quality measures to choose from, whereas with MVPs, depending on which one you select, there could be 12 to 18 to choose from. For the IA category, people reporting through traditional MIPS will have 104 IAs to choose from, and those participating in an MVP will select 15 to 20. There are no differences between MIPS and MVPs when it comes to the promoting interoperability or PI category. This slide shows the timeline for how CMS is transitioning from traditional MIPS to MVPs. CMS plans to eventually sunset traditional MIPS and make MVP reporting mandatory for all eligible clinicians. The first MVPs were available for use in Performance Year 2023, and for 2025, there are currently 21 MVP options to choose from. Subgroup reporting will be mandatory for multi-specialty groups who report via MIPS, who will report via MVPs beginning next year in 2026. And just as a reference, a subgroup is a subset of clinicians from the same group identified by the Taxpayer Identification Number, or TIN. At the end of this session, we will share specific resources to learn about subgroup reporting and the transition from traditional MIPS to MVPs. Again, we will share resources at the end of this session so that you can find more information about the MIPS and MVP reporting session. In the meantime, below are some key takeaways. You must be a MIPS eligible clinician to report using an MVP. You cannot volunteer report or opt in. Each participant can only report on only one MVP. However, there is a way for individual clinicians to participate in more than one MVPs. Registration for the MVP must be completed between April and December. If you are planning to report the CAPS measure, you must register early. The link to more information will again be shared at the end of this session. You do not have to report for the MVP you registered for, and even if you report an MVP, you can also report traditional MIPS or the APM performance pathway. CMS will use the highest score for your payment adjustments. And as with traditional MIPS, if you report more than 4 quality measures, CMS will select the highest scoring measures. I will now hand it back over to Karen. Thank you.
Thank you, Keonna. I hope that was helpful for you. There's a lot of detail with the MVPs, just like there is with traditional MIPS. So we are really excited to share information with you about the new Urology MVP. Its formal name is Optimal Care for Patients with Urologic Conditions, MVP. And it was quite a while in the making. So if we can go to the next slide, please. The development and approval of this MVP spanned more than 2.5 years. So back in early 2022, interested stakeholders began a consensus-based process to draft an MVP for urology. So this process unfolded over about 16 months, the drafting portion, and it was driven by a partnership between the AUA, LUGPA, and Johnson & Johnson Healthcare Systems, Inc. And that was the group who funded the work. It involved bringing together an advisory council of urologists, oncologists, administrators, payers, patient advocates, and again, representatives from the AUA and LUGPA. And through this process, participants considered all of the quality and cost measures and the improvement activities that were available for MIPS and identified the ones that they thought were most relevant and useful for the field of urology. So through a series of virtual and in-person discussions, this group narrowed down their selections to conform to the framework that CMS desired. And that framework, relates to wanting measures that were relevant to the topic of the MVP, having IAs that were aligned, cost measures that were aligned to the extent possible. And CMS also had some guidelines in terms of how many measures and IAs they wanted to see in these MVPs. So major considerations of that group included the desire to include enough measures so that the MVP would be flexible for many providers who provide urologic care. So not just those who provide care for, say, prostate cancer or other cancers, but to be wider in terms of conditions that are treated. And similarly for the ways in which the data are collected. So having a mixture of types of measures. And similarly for the improvement activities, the group wanted to include those that would help promote access to care, enhance care planning, kind of focus some on patient-reported outcomes, promote health equity, and also foster practice improvements and population health. So those were the kinds of IAs that they were thought were important for this MVP. Once the MVP was drafted, the group solicited feedback from several groups within the AUA and LUGPA, and we also sent it out to AQUA participants and asked for feedback. And we took that feedback and revised the draft somewhat, and finally submitted that draft to CMS in the fall of 2023. And then the rest of that time frame was the back and forth through the rulemaking process that CMS has. So I guess I do want to mention that CMS owns MVPs. So, and CMS made it very clear that they have the final authority. So, as a group, we drafted this MVP and submitted it, but we had no control over what they would keep in it, what they would add to it, that sort of thing. However, we did have conversations with CMS, and then we took advantage of the opportunities in January, a formal opportunity to comment, and then again in the summer of 2024 to comment on various versions of the draft MVP that CMS put out. And I will say that, CMS did revise to some extent based on some of our comments. So commenting is useful. So in November of last year, CMS actually approved this final version of the MVP that I'm going to show you right now in a minute. And we are actually very happy to state that the final version that CMS approved is almost identical to the version that we submitted back in the fall of 2023. So if you will go to the next slide, please. And don't worry, you don't have to squint your eyes too much. I'm going to have slides with bigger print in just a minute, but just wanted to point out that this new urology MVP includes 14 quality measures, 17 improvement activities, and 3 cost measures. And that's what you see on the slide here. But again, don't forget that the MVP also includes that foundational layer that is the same for all MVPs across the program, and those two population health measures as well. So if you go to the next slide, this slide shows in somewhat bigger font the quality measures that are included. Again, there are 14 of them. And I just want to point out a few things about these measures. We were able to address a broad range of urologic conditions. So you see measures around urinary incontinence, BPH, bladder cancer, prostate cancer, and stones, as well as some cross-cutting measures such as clinician caps, screening for social determinants of health, and the patient gains in patient activation measure that CMS wanted in there. The quality measures include process measures, outcome measures, and patient-reported outcome measures. So we're happy about that. 4 of the measures indicated on this slide by asterisks are electronic clinical quality measures, or ECQMs. And also 5 of them denoted with the double asterisks are QCDR measures. So again, remember, QCDR measures are measures that are available only through QCDRs such as AQUA. So finally, actually, CMS just released a little over a week ago the 2025 benchmark files. So we were able to add to this slide. The red carets there indicate which of these measures currently have historical benchmarks. So there are 6 of them, and I'll talk about benchmarks a little bit more in just a couple minutes. Let's go to the next slide. These are the 17 improvement activities that are included in the Urology MVP. And again, you will notice that as the aim of MVPs, several of these improvement activities do align with the quality measures. So you'll see improvement activities that promote use of patient-reported outcomes, developing plans of care, screening for falls, those kinds of things. And also, other things like promoting equity and top health kinds of activities and practice improvement activities. Let's go to the next slide, please. Finally, these are the 3 cost measures that are included in the Urology MVP. You can see that 2 of them are urology specific. And the prostate cancer cost measure is new. It was approved by CMS in November 2024, so for use starting in 2025. And it will be used both in this MVP as well as in traditional MIPS. So that measure is now available. The Medicare spending per beneficiary measure looks at cost of care slightly before and up to 30 days after a hospital stay. So some urology care providers do get attributed this MSPB cost measure as well. So with that, let's go to the next slide. And I'll just say once again that we really did appreciate the time that many of you took to submit questions to us. So we did try to answer as many questions as we could. You may not exactly recognize your question in terms of the text that we use, and kind of played around with the titles a little bit. But let's just walk through these questions that we're trying to answer for you today. Let's go to the next slide. How is AUA supporting the move to MVPs? Well, I just described, we were represented in the group that drafted the Urology MVP. So we were, again, very happy with that work. We do resources. We create resources specific to MIPS and to MVPs now. We have the link on the slide for our 2024 MIPS toolkit and MVP toolkit. We will be updating those to reflect all the new stuff for 2025, hopefully in the next several weeks. Our goal is to have this up by the end of March. We will also be recording this webinar and posting this webinar and possibly some other resources along with it on our website, and you can use that QR code. It's kind of a holder right now, but we will be posting this webinar very soon. Also, the AUA registry supports 3 MVPs, not just the new urology MVP, but also 2 others that we feel have enough measures that some urology care providers might want to consider those MVPs as well. So one is on the Advancing Cancer Care MVP, and the other is the Focusing on Women's Health MVP. So let's go to the next slide. So will the measures in the urology MVP change over time? And the answer there is a pretty almost definitely yes, but we don't know when or why or how it will change over time. So obviously new measures may be developed and approved for use in MIPS. So those could come into the MVP over time, or, other measures that are used in traditional MIPS but weren't included in the MVP this first go around, eventually may make their way into the MVP. And of course, measures might be removed, either because lack of benchmarks, or maybe they get topped out, that sort of thing. So measures can come and go in MVPs, just like they can with traditional MIPS. And again, just to reiterate, CMS does own these MVPs, but they are responsive to comments, and I would just encourage you to make comments when there's opportunity available. Or let us know what you're thinking, and we might be able to incorporate some of your thoughts into the comments that we make, because we definitely do, especially in that summer time frame. We comment on things in the proposed rule. Let's go to the next slide. So what's the deal with the benchmarks? It was a little disappointing that right now only 6 of the measures in the urology MVP have benchmarks. And I guess I'll just get on my soapbox a little bit here and just make sure that everybody understands that really the way that you get benchmarks for any measures in the MIPS program, be it MVP or traditional MIPS, is we have to have enough providers reporting on measures. So there are, some additional requirements, but kind of the big one is you have to have at least 20 different providers, be it an individual group, that sort of thing, that meet the data completeness threshold and the minimum case requirement of 20. So you got to have at least that many submissions for particular measures in order to get a historical benchmark. And I'll point out that, I know sometimes people, especially if they're really kind of focusing on getting the highest MIPS score, because that is related to payment, people maybe only submit the minimum number required, and they submit the ones with the highest score. But it really doesn't hurt in terms of scoring, for sure, to report more than the minimum number of measures, even if your results aren't the greatest, because what CMS does is they will use the measures with the highest number, with the highest score. So it doesn't hurt to submit more measures than is absolutely required. And in terms of getting benchmarks so that we can keep measures in the program that are relevant to what you do, we're going to have more people reporting more measures. So I guess that's my encouragement. I'll probably keep kind of reiterating that. Let's go to the next slide, please. This question, I think the question came in a little bit more along the lines of what is the advantage of MVPs over traditional MIPS? So you saw the first part of this table, Keonna went over earlier in the presentation, but we added a few advantages and disadvantages, and they're not going to be surprising because we've already kind of walked through some of these things. But really the advantages of traditional MIPS is just more choices for both the quality measures and the improvement activities. And that may be particularly better for you if you're trying to maximize the points, because you have obviously more measures potentially that you may be doing well on. Also, in terms of well, the disadvantages of traditional MIPS is you may end up using measures that aren't really relevant for what you do on a day-to-day basis. And I would see that as a disadvantage, because you really want to use measures for assessing where you are and determining whether or not you need to do something to help improve care, and you want to be able to demonstrate the high value care that you are providing. But in terms of other disadvantages of traditional MIPS, the minimum requirements in terms of reporting both quality measures and IAs, there are more. 6 quality measures and 2 IAs. And then in terms of cost measures, there are, again, 35 cost measures. Most providers are not going to we use the term be attributable, but a lot of those cost measures will not be applicable to urologists or those providing urology care, but some of them might. So anything that hits the case minimums, you would be scored on in terms of cost measures. So for MVPs, the advantages are, again, the minimum requirements are lower. So one could see that as less burdensome, and more than likely you would be held accountable for fewer cost measures. Again, the urology MVP, for example, there's only 3. So the most you could be held accountable for would be 3, those 3 in that MVP. But the disadvantages is, again, less choice in terms of the measures that you have available to you. And finally, I added the may be harder for some providers to score well under MVPs, just simply because of the limited choice. If you can only report on a few measures in the MVP, then you have to be doing really well on those measures. So, and that actually is a good segue to our next slide, which someone asked, how will MVPs affect overall clinician reimbursement? Or maybe even more to the point, what you might be asking is, how would reporting via an MVP affect your own practice and the reimbursement that you would get? And I would just say that we are pretty confident that the move towards value-based care is not going away. That's going to stay, and that's going to be true, I think, on the federal side as well as on the private side. So just kind of the overall picture of the move from fee-for-service to value-based care is here to stay. Beyond that, I don't think we can really give good prognostication. There's just too many things to think about. Over time, you're going to have more providers reporting on fewer measures. So as people move to MVPs, there's going to, again, fewer measures, but more people reporting on them. That will affect benchmarks. And in the shorter term, if you already are used to some of those measures and you're doing well on them, that might actually work out really well for you. And benchmarks are kind of a couple years behind, so there might be this time delay in terms of what might happen. But as time goes on, people are really working on a smaller set of measures. And ideally, what this is going to mean is that people will start having higher and higher, better and better results. And, good for patients, right? But the measures might get topped out and then get pulled out of the program or out of the MVP. So there's just, I think what I'm trying to say is what this slide says very well here. We just don't know how MVPs are going to affect reimbursement, at least at the individual level. So with that, let's go to the next slide. All of that, we can't tell you what's going to happen. What are we recommending? Well, one thing we would recommend is for you to start now. Take a look at the MVPs that are available, especially the Urology MVP, and start looking at the measures that are in there, the IAs that are in there, and see if reporting one of these MVPs is even feasible for you. If it's looking feasible, then start using those relevant measures and maybe start thinking about how some of the other measures that maybe you don't currently track, maybe start thinking about how you might be able to track those, and especially before MVPs become mandatory. Again, CMS has said that they are going to sunset traditional MIPS. At some point in the future, so MVPs will be the only game in town. So you want to be ready to do the best you can with the MVPs that are available. If it's not feasible yet for you to report on these MVPs, start putting those necessary processes in place. So just as an example, that screening for social determinants of health measure, look at it, see what it requires. Think about what tools you might use in terms of doing that screen and how you might screen. And, maybe in a year or so, you will be able to report that measure. If you are able to report a relevant MVP, we would like you to consider, and we think it's probably a good idea for you to report that MVP and report via traditional MIPS. You are allowed to report both. And remember that CMS is going to use the highest score in terms of your payment adjustment. So it won't hurt you, other than the requirements in terms of the minimum number is a little bit different. But we really think kind of doing it both ways might be the best for you, and to see how it works. Let's go to the next slide, please. And I know we are very close to the end of time, so I'm going to go really fast, and Keonna will wrap us up really fast. We would suggest that the larger multi-specialty practices start thinking about options for subgroup reporting. Remember, for multi-specialty practices, that's going to be mandatory next year. So that's coming along really fast. It's mandatory for MVP reporting. But larger practices may also want to think about, can they report in subgroups, and what might that look like, and what measures and what MVPs might subgroups of the practice report. And then finally, I've already said it, report on measures that don't have benchmarks. If your results are reasonable, especially regardless of whether you're reporting traditional MIPS or MVPs. Just recall that, newer measures have 5 or 7 point floors. CMS will try to establish a current year benchmark. So even if there's not a historic benchmark, there still might be one, and you might end up doing really well. And again, we'll never get benchmarks kind of across the board if more people don't report on the measures. So with that, I think I'm ready to hand it back to Keonna. Keonna, you'll have to talk really fast. And I'm sorry that we don't have time to take questions and answer them now. But again, if you put some in the chat, we will try to address those after the webinar.
Thank you, Karen. I'll just share a few resources as promised. Here are some key resources that will assist you with better understanding the traditional MIPS and MVP reporting options. There's a website specifically for MIPS, website for MVPs. The QPP Resource Library is a resource that will allow you to look for MIPS-related information based on things like the performance year, as well as the performance category like quality or improvement activity. If you have specific questions about MIPS or MVP that cannot be answered through the website content, please feel free to send an email directly to the QPP Service Center using the email address on the screen above. Lastly, the Quality Measurement Department has resources available for quality improvement, measure-related information, including the toolkits that were mentioned before. If you are interested in getting access to quality improvement courses, patient safety resources, and other leadership information, Please let the quality team know by sending an email to quality@auanet.org. There's an opportunity to get free licenses to access the Institute for Healthcare Improvement, or IHI, open school courses. Lastly, just as a brief introduction, again, the Quality Measurement Department develops and maintains resources to help AUA members improve the quality of care they provide to their patients. The department focuses primarily on healthcare performance measurement and on various types of quality improvement education and initiatives. Karen Johnson, who is our co-host, is the director. Emily Calvert, who's been managing the Q&A and the chat box, is our project manager. And I'm Keonna Confesor, your project coordinator for the Quality and Measurement team. And we thank you so much for attending the MVP webinar. Please feel free to share your questions and be sure to visit the Urology MVP webinar website. In the near future, we'll send a follow-up email to let you know the recording is available and other resources that are related. Thank you for your time and enjoy the rest of your day.